Next, we have Dr. Anil Radhakrishnan from Amada Institute of Medical Science. He is a HOD of cornea and refractive surgery. He'll be talking about PRK and its increasing popularity in recent years. Over to Dr. Anil.
Thank you, Kala. Thank you, Jyoti, for the opportunity. The topic is PRK, the resurrection. I think the resurrection is mainly industry driven. It's not because the PRK, we all prefer PRK nowadays. PRK has a safety and it's a great procedure. Now, if you want to do LASIK, there are hardly two companies which are making the blade LASIK, and everyone is switching to femtosecond LASIK. So that is why I believe PRK has become very popular. But the results are equally good. There is definitely, I think, great scientific evidence to say that PRK is as good as any other ablative laser procedure. So the credit goes to this man, Theo Seeler, who came up with PTK way back in 1983 and PRK in 1987. The advantage of PRK is that there are no flaps. So the flap-related complications you can forget about. So generally we do PRK in people in whom the pachymetry is on the lower side. The keratometry values are either flat or very steep, in whom there is a risk of flap-related complications in LASIK. Then if you have a recurrent erosion or epithelial basement membrane dystrophy, flap will definitely augment it. So in such cases, PRK would be desirable. And if you have a narrow fissure or deep orbit, or the patient is engaged in contact sports, definitely PRK would be better. So nowadays we see a lot of patients who have already undergone a refractive procedure in whom there may be an irregular cornea, post-PK, post-RK or post-LASIK. In such patients, PRK is preferred. So if you look at mechanically the strength of the cornea, Corvus has definitely shown that PRK is superior to any other flap-based procedure. So this is a short series which I had done some 10 years ago. At that time, ICL was not 10 years, 15 years ago in Trivandrum, Chaitanya. At that time, we mainly high myopes we used to do PRK. And if you see the change in spherical equivalent, mean of minus 9.3, it came down to about 0.23. The results are pretty good. It was good then also. It is good nowadays also. The disadvantage with PRK is the pain that it causes. I think we are LASIK, the next day patient is very comfortable. PRK patients keep on crying for a few days. And there is always a risk of PRK haze. So why this PRK haze occurs? That is because of an epithelial injury which causes this interleukin release. And that actually drives an inflammation. And if the epithelium does not heal within a stipulated period of time, there is a tendency for haze formation. So some of these myofibroblasts will go to become fibroblasts, and then that will produce the haze. So if the epithelium gets covered within a few days, then this will not happen. So this is not confined to PRK. This happens in C3R. This happens in corneal ulcer also. If the ulcer heals within a short period of time, the amount of scar you get would be very less. So other contributed things are the inflammatory milieu of the eye. If you have blepharitis or dry eye, this will contribute to haze. So in general, Asians have a higher incidence of stromal haze. So I'll take a few findings from this preferred practice patterns of PRK surgery published in IGO in 2020 is still very relevant. So in the history, I'm not going into much into that. Only thing is, in people in contact sports, you have to be more careful. Then in the clinical examination, you have to pay attention more to the tear film. So if you look at the tear breakup time, meibomian gland disease and ocular surface disease index, if you have mild symptoms, give a lubricant and plan the surgery within a week. If you have moderate to severe symptoms, get down the blepharitis, use steroids, lubricants or doxycycline, get the inflammation on the surface very low, and then plan surgery, which will take usually about 3 to 4 weeks. Intraoperative things, there are two systems which were notorious for producing most PRK haze. It is not relevant nowadays. So what it depends, like people have debated whether the type of epithelial removal will contribute to the PRK haze. Whether you remove with alcohol or with amylase brush or you mechanically remove it, it is all the same. So this is a technique. Whenever I do PRK, I generally tend to use alcohol. So intraoperatively, it's a must that nowadays use 0.02% mitomycin. And actually, we should be doing it in almost all the cases. And previously, people never used to use it for if the amount of ablation was less than 50 microns. But nowadays, I think for Asians, it's better to use it in all the patients. So then you put in a BCL. Intraoperatively, there are people who use ketorolac. You dip the contact lens in ketorolac solution for some time, for a few hours, and then use it, and then the amount of postoperative pain can be reduced. That is possible. I don't generally do that. The main problem with the PRK patients is the postoperative pain. There are things like buprenorphine patches available. It is hardly 1,000 rupees. So this is very good in taking care of pain. I think the plastic surgery people and all routinely use it. Only problem is a small percentage of people get nausea after using buprenorphine. So you have to remove the patch, then wait for 1 day for the nausea to get relieved. But most people are very comfortable. Plastic surgeons, they put the buprenorphine patch 1 day before the procedure, and then the postoperative pain would be significantly less. There are diclofenac patches also, but it is not as effective. And I think nowadays it's not available. So I tend to use the usual tramadol plus paracetamol combination. In very fussy patients, we give ketorolac or diclofenac injection also. Post-operative care, it's very important. You have to make sure that the patient use steroids in the initial 8 to 12 weeks. That is very, very important. Avoid sunlight. UV exposure can augment PRK haze. If there is significant MGD, continue doxycycline for some more time. And vitamin C has a role in preventing haze. If you get a late onset haze, things are different. It's very difficult to treat. You can give topical steroids and lubricants, but tacrolimus is recommended for about 6 weeks. Doxycycline you can use. Vitamin C also, antioxidant dose, 500 milligram 3 times a day you have to use for 3 months, and UV protection should be given for at least 3 months. So, but once you get a late haze, it's very difficult to treat it. Quite often you have to have a repeat procedure, taking care of all the preoperative parameters, getting the inflammatory milieu of the eye to the baseline and then do the procedure. And extremely be careful in the postoperative period also by giving good lubricants and steroids. And whenever, if you're using steroids, better to use, I think in routine we use the loteprednol, but in people in whom there is a haze or there is some more inflammation, you can give dexamethasone or prednisolone acetate. So I would like to conclude saying that PRK still holds a great position in institutions like LB Prasad. I think 2/3 of the procedures they do are PRK. I think about 1/3 to say 1/3 or 35% they do femto and other smile procedure. So if you pay attention to the surface and give good postoperative care, the results are as good as LASIK or any other procedure. Thank you so much.
Thank you, Dr. Anil, for those words of wisdom. Dr. Anil emphasized on the importance of surface ablation. Well, in our practice also, we do maximum surface ablation with excellent results. And I want to stress upon a point that it is not an outdated technique. One need not be afraid to advise. Thank you, Dr. Anil.
That is definitely there. When you are removing the epithelium, the risk of infection is there. So they have to instruct the patients. It's not like LASIK. You can't walk around from the next day. You have to be indoors. You have to keep the patient under good control for the 3-4 days till the epithelium heals.
And what is your mitomycin time?
For every micron, 1 second.
1 second.
Just like you people do. Yes, Punch. I usually put a drop nowadays without even without wetting the surface. Just put a drop and keep it like a pool there. Just 3 drops, so it will remain in that area. Then wash off. No, you should not go to the limbus. Yeah. So only limit yourself to the ablated area. Wherever the epithelium is gone, that area you limit it. So I generally put 2 drops, maximum 3 drops. It will make a drop and remain there. Then at the end of that, we'll wash it off. No, I just put the drop directly now. Now, if you wet it, then it will go to the sides. So just like I think one of the people there, I think that Egyptian is there, no, who do a lot of PRK. That he had made the suggestion. So after that I had been using it.
Anil, will you use cyclosporin to reduce the haze? Yes. Because Narayana Netralaya, they are
Okay.
promoting that 3 months of cyclosporin use will
Before
reduce the,
pre-op?
afterwards,
After
after the
that.
procedure.
Okay. I have not used it. Maybe it
We
works.
are
I don't know.
regularly giving
Giving
for 2
cyclosporin?
months. Yeah.
Okay. I don't know whether there's a relation between the cylindrical power. It's basically the amount of stromal ablation that you do. Okay. Cylinder, if you go beyond 4, definitely there will be some amount of residual cylinder. So even for LASIK or in fact any procedure up to 4, it gives good results. Beyond that, there you can expect some amount of residual power. That I'm not sure. But whatever studies I've looked into, there is no real difference between trans PRK. One of the centers I go, I do trans PRK also. I don't think there is any difference.